The nice thing with the aura is there's actually studies where we can see the electrical wave. We can actually observe it. So can we see the migraine attack? Not the aura, just the migraine attack. And I'm delighted to say that now we can actually see things happening in the brain with advanced techniques. Let's have a look at this. This looks like weird. This is a study. This is a full month on a one woman that went to the functional MRI every day. Every morning she had a functional MRI, and she was presented with different things, a strong smell, some irritation of the nose, and also a visual checkerboard. And you can see in red, she had 3 migraine attacks. And in lavender, it was the day before the attack, and in kind of pinkish, it was after the attack. So we call that sometimes the prodrome, the postdrome. It's like before and after the attack. And during the attack, you can see that the lines, the colored lines go up. So she had a heightened, an enhanced perception of vision, of smells, which is exactly what you expect during a migraine. And so they could record what was going on inside the brain during this. So what did they see? Okay, so now we have to look at the brain. I put a picture there so you can see the whole head, so you have an idea where those yellow dots are. The yellow dots are where there was more blood. So that suggests that something is going on there. There's some activity. So before the migraine, the hypothalamus, which is a zone that is deeply linked with our hormones and our balance in the body, the hypothalamus was actually active. And we saw that this hypothalamus zone was talking quite strongly to what we call the trigeminal nucleus. We'll talk more about that, but this is a zone that computes all the sensation of, you guessed it, the face and the neck and the sinuses. So it's like this zone, the hypothalamus, was talking to the zone that just collects all the sensory information of our head. And then during the attack, there was another zone, the middle red dot, we call it the pons, and we don't know exactly what that is. We think maybe it's a moderation, it's a modulator. This zone, there are pain control centers there, and also serotonin nuclei or serotonin places. Okay, so sorry for the medical jargon, but I wanted to show you this because this really tells us that there's something going on inside the brain during a migraine attack, that we can see it. And this has been actually shown in previous studies. So it's not just a study. This replicates other findings. Okay, so we know something's going on. And then what do you know if you have migraines? I have migraines. I know the pain. And you feel the pain somewhere. But sometimes you will feel it in your temple, in your eye, typical. But other people feel it in their sinuses, in their necks, in their jaw. So where does the pain come from? Because all those things are normal. You know, your eye is fine, your neck looks okay. So where does the migraine pain come from? Here's that word again, trigeminal. That means 3 Gemini or 3 triplets, if you wish, for the 3 branches of this big nerve that carries all the information from the face, but also the teeth and the sinuses and the eye and the nose and everything. And it goes to a center in the brain, this little dot I showed before, the nucleus. So all those branches, they take a signal for touch and pain and vibration and hot and cold. They just take all of that to the center. But the interesting thing is that those nerves or those branches do not carry information only from the eye or the sinuses or the teeth. They also carry information from the meninges and arteries inside the head. So inside the head, the brain itself, okay, I know when you have a migraine, you can feel like your brain's gonna explode. The brain doesn't feel any pain. What feels pain is meninges and blood vessels, arteries and veins. You can remember that if you think about meningitis, an infection of the brain, a super painful, big headache there, or rupturing an aneurysm, you know, having a bleed and a brain hemorrhage, that's very painful too. So inside the head, meninges and arteries are painful. They can sense pain. That's what they do. And the nerves that are connected there are the same nerves from the same branches that connect to your temple and eye and neck and sinuses. So do you see something building here? The cause of the pain in migraine is most probably an inflammatory soup of peptides, proteins, that are released on the meninges and the arteries inside your head, okay? So those peptides are released by the same nerves that actually feel the pain. That's interesting. You can imagine like this electrical wire that can actually sprinkle cayenne pepper on your meninges, and that creates the pain that you feel. And with that pain comes the hypersensitivity, sometimes the pulsation sensation that you have. So that is the cause of the migraine headache. That's an inflammatory soup that is released near your meninges and arteries. And this soup causes inflammation. So that means that the blood vessels dilate. And some people can actually see during a migraine that their vessels of the face and the head become dilated. Before we thought that the dilation was causing the pain, but now we know that the mechanism is that there are those peptides and they cause the pain and they cause the dilation together. Okay, so now we said a lot already about the genes and the proteins and the pain and the trigeminal nerve. So now let's talk about the neck, because a lot of people with migraine, including myself, have neck pain during an attack. And so they think that something's wrong with their neck and that the neck should be fixed properly. So is the cause of migraine in the neck? And that's a perfect example to introduce the Ping-Pong Theory. So let's talk about the myocardial infarction, the heart attack. Everybody knows, kind of a social, something that people know, that when you have a heart attack, you can feel pain in the chest, but also pain in the left arm. The left arm is okay. It's the same networks cause the pain in the arm and the heart. So we call that a referred pain, a pain from somewhere that's felt somewhere else. So now what we have to understand is that the head and the neck are deeply connected. Those electrical wires I talked about, those that take care of the eye and the temple, they actually take care of the neck as well. They connect. So the big wire that comes to your eye and temple is connected to the same place that connects to the back of your head. So it's a two-way road. And by the way, there's another zone that's connected. It's the zone of the jaw, all right? So those nerves also connect all in the same place in this trigeminal nucleus. So that means that the pain of migraine can come from the soup in this area and can actually be felt at the back of the head. But the process can also be reversed. So you can actually have tension in your neck that triggers the migraine attack because it irritates the system. So it's both ways are possible. So if I look at my own case, I never have neck pain, very rarely. Or if I do have it, it's both sides at the back of my head when I train too hard and it's not a migraine. But during the migraine, I have pain only on the right side, and usually it comes after all the rest of the migraine attack has started. So it's really a two-way road, and we have to understand that it can go both ways. Interesting, isn't it? Because that's true for so many other things. So now that I've talked about the neck, you can apply the exact same thing to a lot of other things. For example, your brain, if you live with migraine, has to compute tons of information every day. So there's the stress. Stress can be anxiety, can be also mental load, how many decisions you make per day. Inflammation, if you live with an inflammatory condition. Emotions, like how we react to difficult emotions related to others. Every sensory input, so that means, is there pain in your neck? Is there inflammation in your sinuses? Hormones. How is the sleep? The sleep allows the brain to function better. All of those things influence the migraine brain that has this particular software and the ability of triggering this attack with the soup. Okay, so that leads us to the migraine threshold theory that we do teach a lot in headache clinics. We tell people that they can have multiple triggers and that those triggers accumulate and they combine So the perfect example is if you had a stressful week and then you have a long Friday and then you don't hydrate, you eat crap, and then eventually you decide to go out, you have alcohol, and the next morning, boom, you didn't sleep very well, you don't take your coffee, you take your breakfast later, and then you have the migraine attack. So that's one example, but there are many others. You know, you exercise on a ski slope and it's very, very bright, lots of light, and then your neck gets tense. All of those things combine to trigger the migraine attack, and then the cascade, and then the inflammation, and so on. There's another condition that works a little bit like that. I'm going back to asthma. So asthma is actually a hyperexcitability of the lung. During an asthma attack, there's a lot of inflammation. Migraine is hyperexcitability of the brain. So you can have mild asthma where, you know, you get rid of the cat, you're good. You just manage your allergies, you're good. But then you have severe asthma where you need a bunch of treatments and a neurologist to help you. The same goes with migraine. You can have migraine treated by stopping, you know, alcohol, for example. Or you can have migraine that gets better if you just lower your exercise intensity. But a lot of people have migraines that actually they live perfect, pristine, saintly lives, and still they have migraine because just living is too much for their brains, and they need medical care and prevention. So this brings us to a bit of a different topic. It's not necessarily about the cause of migraine. We've covered that. But it's about how those different softwares influence the different types of people with migraine. So you can have migraines a few times per year if you're lucky, and then that we call that low frequency episodic. So that means that some lucky people have very occasional migraines, maybe triggered by very precise things, and they might not require medical care at all. And those people sometimes, you know, just take their own example and say, oh, I treated my migraine by whatever they're doing. But then there are more severely affected people who have more frequent migraines. And then the brain starts, you know, being in the pre or post migraine on a regular basis. We call that frequent episodic. And then you have the chronic migraine. So that's the state where you're always somewhere in between, you know, you're just back from a migraine or you're starting a migraine, and you have very rare headache-free days and very frequent migraines, and sometimes very severe. So this is a continuum, this is a spectrum. And we usually separate people according to their frequency and also the presence of headache-free days. So that means that for some people, when we care for migraine, we want to care for the brain, right? Of course, we want to address the triggers. We want to make the brain, you know, in a good place. So you have to find this balance between avoiding triggers, which is very, very stressful, or just promoting healthy behaviors. That can be a bit more empowering. So this little lady here, superhero of migraine, she does the whole thing, and then she puts her brain in a nice place, and maybe she controls the migraine situation with that. But for some people, even doing that is not enough. Because when you fall in a migraine chronification, so that means people, maybe some of you have this, they started having migraines when they were young, or, you know, anywhere in their 20s, and they had occasional migraines, everything was okay. And then eventually, sometimes something happens, we know, sometimes we don't, and then you fall into the chronic migraine state. So this brain that has the software that triggers attacks becomes just in a cycle where everything is completely, you know, like unstable. So you lack sleep, you tense your muscles, your relationships with your family, your workplace become a little bit tense, you're missing stuff, you have to compensate for that. And then what you do, you try to take medications, you fall into medication overuse, maybe you drink more caffeine, and then you cannot exercise, and then you cannot cook, and then so this is the vicious circle of chronic migraine. And this is not easy to break, as some of you might know. So many vicious circles there. Overuse, sleep, mood, sinus and jaw and neck pain, the big trio. So this can actually put people in a very tough place. So that's what I call the ping-pong theory. And if you understand this cause of migraine thing, then you can actually picture how migraine should be cared for. And I know a lot of people with migraines say, I don't want to take pills, which perfectly understand. You know, it makes a lot of sense. You don't want to take anything chemical in your body. And why would you do that? So actually stabilizing the lifestyle is always a very good thing. And it works both ways. So the ping-pong theory leads to the fact that you can either raise the tolerance of the brain itself, right, to make it more resistant to the migraine, or you can decrease the load in the periphery. You can manage the triggers, and both are good. So the stabilizing lifestyle works both ways. It actually stabilizes your brain, and it also decreases the triggers. So that's good. Medications that we give and prescribe can actually change this chemistry, electricity, software balance of your brain and higher your threshold. So your brain does not trigger the attacks anymore. Exactly like asthma, people with asthma will take different things to kind of quiet down their lung. So medications and migraine work that way. Are they perfect? Absolutely not. Are they effective for everyone? Absolutely not. But they can really help the brain to stabilize. And then, of course, if you have sleep apnea, well, treating the sleep apnea might actually help your brain. If you have absolutely big, like neck issues, shoulder issues, absolutely seeing someone to take care of your neck with exercises or with different approaches can help. And if you do not tolerate gluten, it makes sense to stop gluten. But you can understand now that for every person, there is actually a mix of things. So it's impossible to just know from the start, you know, what should be done. And usually just managing stress and drinking more water is very good, but it might not be enough. So when we manage migraine in the clinic, usually we do the behavioral part, which is everything related to lifestyle and natural things, acute therapy, and preventive therapy. So I want to say just a few words. I said I wouldn't talk about treatments, but some of you might be very curious about those treatments. How do medications and Botox and CGRP antibodies work? Medications might be propranolol, amitriptyline, verapamil, Topamax, or topiramate. All those medications change the chemistry of the brain one way or another and stabilize it for some people. Botox is interesting because Botox actually stops the nerves from releasing the inflammatory soup. It stops the release of the peptides, like CGRP, for example. We'll talk about CGRP. So Botox acts, you know, not inside the brain. It acts in the periphery. Remember the ping pong game. So it actually quiets down the nerve terminals and also maybe releases or relaxes some tight muscles, but that's not the key thing. So it relaxes, it stabilizes the nerves of the head and neck, and to decrease the sensory load, we think, on the brain. CGRP is one of the things in the inflammatory soup. It's a peptide, right? And there's a lot of focus on this peptide in these days because we have successfully, companies have successfully targeted this peptide with antibodies. The antibodies block the peptide, okay? So they prevent the peptide to act, or they bind a receptor and they stop this kind of CGRP interaction that plays a role in migraine. So this is how our preventive medications work. There will be more seminars about this, but just to explain a little bit, now that you've seen the cause of migraine, how we target it using different chemical things to stabilize the brain. So you can imagine, just to illustrate a bit what I mean, that your personal therapeutic plan will be very different depending on who you are. So here I show you two completely fictional examples. Damien, so Damien's a guy, he's 48. Men have migraines too. He's a hyperachiever on the anxious side. He really wants to do things perfect. He has hypertension, and he doesn't sleep very well, poor Damien, and he drinks tons of caffeine to go through the day. And then when he has a release after a big rush at work, then poof, the migraine hits. When he's exhausted, when he trains very hard. And then NSAIDs or anti-inflammatories do not fare very well with Damien. And this guy has 8 to 10 days per month of migraine. So he has frequent episodic. And then we have Cynthia. Cynthia is a completely different person. She's a woman. She's 32. She had a tough childhood. She has a history of depression. She has fibromyalgia. She's a bit overweight. She also has insomnia. Insomnia is very common with migraine. She did stop caffeine. She probably has some degree of analgesic overuse because she has frequent headaches, and she treats them with Tylenol and NSAIDs and triptans. And she tried 2 preventives, and she doesn't know where to go from there. So the plans for Damien and Cynthia will be very different, right? Damien probably needs a bit of education about how to manage stress, how to improve sleep, maybe address the caffeine issue, and then maybe treat the attacks better. And we could give him a preventive and take care of the hypertension and the migraine at the same time. Cynthia would probably need help with exercise, to adapt exercise for her so she can deal with fibromyalgia better. She would maybe need a bit of psychotherapy to address the emotions, and she needs a better preventive. So maybe Cynthia would be a candidate to get Botox or a CGRP antibody. So those are different types of patients we usually discuss in doctors' meetings to illustrate how migraine should be managed according to who you are, and not according to cures or recipes or, one size fits all approach. So this is where the migraine tree comes. On the Migraine Canada website, you will see this migraine tree. It's being designed for us, and it illustrates this diversity of options, actually. So in the roots, you can see who you are as a person with migraine. Are you a woman with hormonal issues? Are you a child? What type of migraine do you have? What's your psychological background? What's your medical background? So all of this roots, goes on what is your system like. Then in the trunk, the core, is what every person with migraine should know. So everyone, if you want to have a look at this category, those posts, this is all about what I just said today, the cause of migraine, what's a placebo response. It's important to understand that, how to do a diary, what is an acute treatment, a preventive treatment, basics really. And then you go into the branches. All the branches are equal, So, and I didn't put alternative treatments there. I put self-care and lifestyle, social life, how to deal with the workplace, the partners, children, how to break the attack, how to prevent the attacks, and then the world of devices and neuromodulation. We don't have a lot of that in Canada, but it's coming. And the world of procedures and injections. Some procedures and some devices might actually be acute and preventive. So it's a bit complicated, but overall, I invite you to explore those branches. And I hope you find what you seek on particular treatments. So that's the vision of migraine, a very holistic approach that includes everything that can help you get better. So just a few examples what you can find in the branches, about the, for example, lifestyle is all about physio, exercise, sleep management, life situations. We're building that category. So how to deal with school, how to deal with travel, the acute, how to use the acutes, how to combine them, how to avoid overuse, and then the world of prevention and procedures and blocks and things like that. So will that replace an actual psychologist or an actual nutritionist? No, it won't. But it will give you a little bit of basics to grasp a little, how you can tailor your own plan. So in conclusion, you're so good to have stayed here with me listening to all that scientific stuff. I really hope that I demonstrated to you that migraine is a neurological disorder, right? It is not just a headache. It is not imaginary. It is not in your head. It is a question of genes and proteins and software. It is very diverse, both on symptoms, on triggers, and on treatments. So you cannot just rely on this person on this forum who said that this worked. Maybe it worked for this person, maybe not for you. So you really have to look at your situation to find your options. So you're not crazy. You're not crazy. You're not alone. Absolutely not. Even if you suffer from chronic migraine, I mean, 1 to 2% of the world's population is like you. So you're not alone. It's just because no one talks about it. That's why I'm here, to talk with you and to share with you. Migraine is disabling, not for everyone, okay? But if you have a lot of it, it can ruin a life proper, right? It can take away from you your job, your social activities, your travel, your sports. So if you are disabled by migraine, believe me, you're not alone. You deserve care like any person living with a chronic condition, diabetes, asthma. So if you look for diabetes and asthma and cancer or all of those things, there are programs for them, right? There are diabetic educators, nurses, specialists, clinics. So treatment actually must be adapted to your situation, just like for any chronic disease. So why on earth are waiting lists for headache clinics so long? Well, there's not only a stigma on patients with migraine, there's also a stigma on migraine in general, and that includes migraine as a scientific topic and migraine as a clinical specialty. Let me tell you, a lot of us headache specialists have been stigmatized. We have been treated as the poor child of neurology, all right? And this is probably because people, we didn't have proof, we didn't have science, we didn't know 20, 25, 30 years ago. But now, and we have what I've shown you, I think it's time for migraine and other headaches to gain a little bit more of attention and to be considered as a serious neurology specialty. And also other specialists can help people with migraine. So if you wonder why your doctor doesn't know any of this, they probably know more than most of doctors now. Well, it's because they're not trained. This is not part of the typical med school program, you know. This is not part of the training of many GPs. So this has to change. Also, we're working on a database of headache clinics to build a clinic locator, but we have to define what clinics are. Ideally, a clinic would be a place where you can find, you know, a nutritionist that gets migraine, a psychologist that gets migraine, a physiotherapist that's good with the neck and shoulders. But those multidisciplinary clinics do not exist for migraine, or very, very rare in Canada. So we need more of that. So you can get better, not only with pills, but also with skills. Okay. So we need to improve the system. We need to break the stigma. We need to unite and speak up and get organized. That's what Migraine Canada is about. We need to increase awareness in schools, workplace, politics, and we need to organize multidisciplinary programs with nurses and psychologists and physios to help you take care of your brain. This exists for cancer. It exists for diabetes. It exists for asthma. It exists for arthritis. It exists for Parkinson's disease. So we should have it for migraine, but we need your voice and we need your support to have this happen. So a call to action for now, just stay tuned on Facebook. This is the key social media that we're managing at present time. You can please share Facebook, share and speak up, recommend our tools if you like them, recommend our resources, bring this to your doctor, make your doctor aware that we exist. Don't hesitate to talk about migraine to your networks. Don't be ashamed. Don't feel guilty. Participate to our surveys. We will poke you a little bit to have some insights. We want to know how to act on your behalf. Volunteer with us. We're looking for different volunteers all the time, so never hesitate, even if it's just to write a little thing or to put a poster at your workplace or something that can increase awareness. And then together, I think in a few months and years, this will build up and the care for migraine in Canada will be better. Thank you for bearing with me. I know this was a long talk, probably too long, very, very scientific based, but I really hope that you enjoyed it, that you found it helpful, that this will help you manage migraine or care for the person with migraine that's close to you. So be well. Thank you. And I hope I'll see you again for future webinars.